The general health status of the mother has also an impact on the sexual function. Women who experience severe obstetric morbidity, such as eclampsia, intrapartum hemorrhage, sepsis, ICU admissions, are more likely to report poorer general health 6 to 12 months post-delivery and hence experience a delay in the resumption of sexual activity. Good afternoon, everyone. Thank you, sir, for the kind introduction. I thank IASMPMM for this opportunity for me to talk on this post-delivery sexual dysfunction. So from morning, we have been discussing about this. Women's sexual health is a vital and important part of life at any age, and it's influenced by many factors. Pregnancy and childbirth is a special period in a woman's life which involves significant physical, hormonal, psychological, social, and cultural changes that influences our own sexuality as well as the health of the couple's sexual relationship. Now, this transitional phase prepares the couple for new roles as parents. For the first pregnancy, the transition takes place from a couple becoming a family and from being a person in a relationship to motherhood and fatherhood. As with any transition, there may be a sense of loss as well as excitement of entering another phase of one's life experience. Now, postpartum sexual function is an important issue for couples since the first postpartum sex is an important step for the couples to establish their sincere relationships. Studies have shown that the prevalence rates of sexual dysfunction at 2 to 3 months postpartum is as high as 70%, and this decreases to 55% at 5 to 6 months postpartum and further decreases to 30% at more than 6 months postpartum. Now, is there a need to address this postpartum sexual dysfunction? Yes. This is because it decreases the quality of life of the lady and hence negatively affects all aspects of her health. It increases dissatisfaction with others and aggravates social problems like divorce, crime, and drugs. It also reduces sense of femininity in the lady, reduces her self-confidence and security, paving way for various mental and physical diseases. Now, in this course of talk, I have divided the topic into possible etiopathogenesis, that is the possible factors causing sexual dysfunction in the antepartum period, intrapartum period, and the postpartum period. I'll be quoting few studies to support the facts, and ultimately concluding with a clinical approach for prevention, evaluation, and treatment of postpartum sexual concerns. Moving on to the antepartum period. Now, specific changes occur in each trimester of pregnancy, which may significantly impact her sexual behavior. Now, it has been proved that sexual function declines throughout pregnancy, particularly during the third trimester, and may persist during the first 3 to 6 months postpartum. Bairami et al. In his study showed that 69% of the postpartum ladies, 69% of the ladies in third trimester suffered sexual dysfunction. Sexual desire disorder was the most commonly reported sexual dysfunction in each trimester of pregnancy, followed by orgasmic disorders and arousal disorders. Now, there are various physical factors that are associated with this decreased sexual activity. The most common involved fatigue, nausea, vomiting, which are common in the first trimester, pains, infection, pelvic congestion, more common in the third trimester. Few women perceive this altered body image as lack of attractiveness. Moving on to the obstetrical causes in the third trimester, it can be due to the discomfort caused due to the engagement of the fetal head or associated stress incontinence or hemorrhoids, fear of weight of the part on the uterus during sexual intercourse, pains due to subluxation of the joints, vaginal discomfort, pain, laxity, or pelvic vasocongestion resulting in dyspareunia. Bogren et al., in his study on primiparous women, concluded that sexual satisfaction declined with advancing gestational age. It was noted that 55% of the male and 76% of the female in the third trimester perceived decreased sexual satisfaction. Coital frequency also declined with advancing gestational age. 41% of the couple experienced decreased coital frequency in the third trimester. Length of intercourse and experience of orgasm also decreased. Studies have shown that 94% of the pregnant women experienced diminished clitoral sensation, followed by lack of libido and orgasmic disorders. Now, the increased levels of various hormones like estrogen, progesterone, prolactin, which is responsible for the symptoms of pregnancy, causing the physical causes of sexual dysfunction, were also responsible to reduce the sexual desire and arousal. Hormone relaxin was known to decrease the vaginal sensation. Psychological changes. Now, sexual difficulties during pregnancy may be a psychological in origin, occurring as an emotional response to the changing or changed state. The various psychological factors relating to pregnancy that affect the sexual desire include anxiety of delivery and motherhood, changes in the couple's rapport or relationship, the negative psychological sequelae of miscarriage, lack of self-esteem, and sexual guilt. There was an increasing self-consciousness about a growing and protuberant abdomen, which influenced his self-confidence, and it also posed physical limitations to performing some sexual positions. Now, this concerns of the body image and general health status worsened 3 to 6 months post-delivery. Now, there are certain absolute and relative contraindications during pregnancy when sex is contraindicated, like placenta previa, preterm rupture of membranes, and preterm labor. The risk of an adverse pregnancy outcome as a result of sexual intercourse should be individually considered and discussed with the patient or the couple. Outside these contraindications, loving relationships and intercourse can be continued. Fears and myths that sexual intercourse results in fetal injuries, miscarriages, infection, bleeding, and preterm labor has also been propagated, which results in further avoidance of sexual intercourse. Errol et al. In his cross-sectional study noted that 41% of the pregnant women in the third trimester refrained from engaging in sexual activities because of the risk of preterm labor. Experiencing an adverse pregnancy outcome such as miscarriage, stillbirth, or adverse or debilitating neonatal morbidity adds additional stress in a couple's sexual relationship. Primiparous women experienced more dyspareunia, probably because of higher rate of severe perineal trauma, and also they felt less secure about the postpartum sexual life because of lack of experience. Moving on to the intrapartum, spontaneous delivery and assisted vaginal delivery are both associated with short-term damage to the perineum and long-term changes to the pelvic floor. Now, many studies have attempted to answer this question as to do these intrapartum changes influence sexual function. The findings are quite controversial. The general health status of the mother has also an impact on the sexual function. Women who experience severe obstetric morbidity, such as eclampsia, intrapartum hemorrhage, sepsis, ICU admissions, are more likely to report poorer general health 6 to 12 months post-delivery and hence experience a delay in the resumption of sexual activity. Compared to women with intact perineum, women who had episiotomies complained of increased perineal pain, decreased sexual satisfaction, and delayed return of sexual activity postpartum. Now, as per the guidelines, nowadays restrictive episiotomy has been practiced. That is, episiotomy is given only for indicated conditions. Now, a study involving restrictive episiotomy versus routine episiotomy showed that 37% of the lady who underwent restrictive episiotomy resumed sexual intercourse by 1 month after delivery compared to only 27% in routine episiotomy. However, in the extended trial, that is 3 months postpartum and 3 years postpartum, the rate of dyspareunia was similar in both the groups. Cochrane did an extensive review and concluded that there's no difference in the presence or lack of episiotomy in women reporting painful sexual intercourse 6 months or longer after delivery. So to summarize, episiotomy is not defined as a risk factor for painful sexual function. Now, based on the accumulated data, it is noted that assisted or operative vaginal delivery are associated with a negative effect on sexual function, probably because of associated pelvic floor disorders like anal sphincter injuries, urinary symptoms, and pudendal neuropathy. first and second degree versus third and fourth degree perineal tears. Now, episiotomy comes under the second degree tear, while obstetric anal sphincter injuries come under the third and the fourth degree perineal tears. A prospective study with 377 primiparous women found that women were 5 times less likely to be sexually active after third and fourth degree perineal tears. Another prospective study also showed that the ladies who experienced third and fourth degree perineal tears were negatively affected by sexual function even at 6 months and 1 year post-delivery. In a systematic review of 14 studies comparing the third degree, fourth degree perineal tears with first degree, second degree tears, showed that the frequency of dyspareunia at 3 months was as high as 50 to 64% and decreased to 20 to 30% at 6 months. The average time of renewal of sexual activity was also delayed in third degree, fourth degree perineal tears. Now, this is an important question. Is elective LSCS preventive of sexual dysfunction? Griffith et al. Demonstrated a significant decrease in sexual satisfaction scores in women who underwent vaginal delivery versus those who underwent LSCS. And this is probably because of the increased prevalence of urinary incontinence, fecal incontinence, and fetal incontinence in those who underwent vaginal delivery. Another study by Klein et al., who examined primipara vaginal delivery versus primipara elective LSCS, concluded that the rate of dyspareunia at 3 months after childbirth was higher in those who underwent vaginal delivery. Cesarean delivery appears to decrease the incidence of dyspareunia in the first 3 to 6 months postpartum, but has no effect beyond this time frame. And this protective effect is most likely due to the absence of perineal injury. And Hanna et al., in their long-term breach trial, concluded that the sexual function at 2 years made no difference in both the groups. While genital tract trauma can impact postpartum sexual function, it must be considered in the context of women's relationship with her partner, as well as her relationship with her own body. A woman's satisfaction with her relationship has shown to be having a larger impact on sexual satisfaction than trauma at childbirth or the mode of delivery. An important aspect of women's life during the postpartum period is lactation. Breastfeeding is strongly encouraged by both pediatric and obstetric organizations because it has a positive effect on the maternal health. Lactation has a profound effect on the postpartum hormonal levels. The elevated prolactin levels results in decreased ovarian production of androgens and estrogen, which may be a factor in decreased sexual desire. The lower estrogen levels may negatively affect vaginal lubrication. However, it has been noticed that oxytocin released while breastfeeding has positive effect on the mood of the lactating lady. Lactation results in increased sensitivity of the breasts, which makes stimulation during sexual foreplay uncomfortable for the breastfeeding women. Sexual desire may be decreased by fatigue because of the need of nursing every few hours throughout the night, resulting in a state of chronic sleep deprivation. Several studies have concluded that breastfeeding has a negative effect on the sexual function postpartum and hence delayed the resumption of vaginal intercourse after childbirth. However, there are a few studies which showed that breastfeeding did not affect most women's sexual relationship with their partners. And these studies demonstrated the partners' perception attitudes towards breastfeeding and sexuality were positive. Postnatal depression affects around 8 to 20% of the women. Underlying mental health conditions such as anxiety and depression may appear or become exacerbated during pregnancy and postpartum period and is often underdiagnosed and undertreated, which has an impact on the couple's sexual health. Now, depressed women are known to have decreased sexual desire, resulting in further increase in postpartum sexual dysfunction. Also, medications used to treat postpartum depression may be an etiology of continued sexual dysfunction. A review estimated that SSRI-related sexual dysfunction occurs in around 30 to 50% of the patients. During pregnancy, we saw that there was no decline in the sexual practices that are preferred by the male partner, but there was a reduction in female-oriented activities reflecting the lower desire in the pregnant women. Now, this has also been shown that the male interest toward their partners remained mostly unchanged until the end of second trimester. During childbirth, it was the partner's reaction to birth process which had an impact on the new mother's sexual health. During the postpartum period, the probable cause of sexual dysfunction was mainly because of anxiety of the new father, becoming a new father, fear of causing pain on sexual intercourse, jealousy of the mother and the infant bond, increased responsibilities because of the presence of a child. Contraception. Some women may defer resumption of sexual activity or experienced sexual dysfunction as a result of concerns about becoming pregnant again. Hence, highly effective postpartum contraception, including the long-acting reversible methods, should be discussed with all women during the prenatal and the postpartum care. Now, when to resume intercourse? Now, resumption of intercourse was noted to be around 41% 6 weeks, and it was almost 78 to 90% at 12 weeks after birth. Here also we noticed that around 1/5 of the women have not had any type of intercourse 3 months postpartum. The decision to resume intercourse after childbirth should be made mutually between the women and a partner. The ACOG and the AAP guidelines for perinatal care indicate that the earliest time at which the coitus may be resumed safely after childbirth is unknown, but the risks of hemorrhage and infection are minimal by 2 weeks postpartum, so hence considered as safe after 2 weeks postpartum. Clinicians typically recommend that women may be considering resuming sexual intercourse after 6 weeks after delivery, which is typically after their first routine postpartum visit. This allows them sufficient time for uterine involution and also surgical and vaginal or perineal wound healing and suture reabsorption. Coming to the clinical approach for prevention of and evaluation and treatment of postpartum sexual concerns. This first involves initial assessment followed by counseling. So in the antepartum period, we have to rule out all the factors which are causing sexual dysfunction. That is, we'll have to ascertain whether the pregnancy was planned, was it contraceptive failure, what is the outcome of the previous deliveries, how were the previous deliveries, was there any perineal trauma? Yes, sir. What is the health of the current child? Assessment has to be done to the current and the past sexual relationship. We have to determine any sexual dysfunction was present before pregnancy. We have to explore patient's couple's support network. We have to watch out for any abusive or strained relationships and intimate partner violence. We also have to evaluate for the presence of any depression or any use of medications during pregnancy. Counseling in the antepartum period involves discussing the changes in anatomy, physiology, and sexual function and avoid pathologizing any range of any sexual changes. We have to discuss the likely safety of continuing sexual activity and incorporate safe sex practices. We have to discuss alternatives to intercourse and acknowledge the importance of maintaining intimacy, enabling partners to discover new and satisfying ways of expressing their sexuality. Also, we've got to encourage women to raise sexual concerns and have open conversations about sexuality during pregnancy and postpartum with the healthcare provider. We have to encourage women and couple to discuss about the course of pregnancy, delivery plans, prenatal exercises, lactation, and care of the newborn to prepare them better and hence reduce physical stress and emotional strain. We also have to encourage them to attend antenatal classes and take educative videos on the above topics. Coming to the intrapartum period, it requires the need of judicious use of operative vaginal deliveries, use of restrictive episiotomy, early detection and repair of the anal sphincter lacerations, repairing the perineal lacerations with synthetic absorbable sutures, discussing perineal pain, dyspareunia, and initiation of postpartum sexual activity before hospital discharge, and encouraging postpartum pelvic floor muscle training. In the postpartum visits, we have to assess for the sexual function and address concerns, assess for perineal repair, assess for any presence of urinary and anal incontinence symptoms, encourage vaginal lubricants, particularly in breastfeeding women with a physiological hypoestrogenic state, assess for postpartum mood changes, encourage adequate rest and time for intimacy, promote a positive perception attitude to the male partner towards breastfeeding and sexuality, encourage women and couple to discuss about contraception, postnatal exercises, lactation, and care of the newborn with healthcare professionals and to prepare them better to reduce the physical stress and emotional strain. To conclude, postpartum sexual health is a common concern but seldom discussed. Most women do not seek professional help due to the embarrassment and preoccupations with their newborn. Prenatal visits are an ideal time for the healthcare providers to address these concerns with expectant mothers. Healthcare professionals should consider the sexual problems of the women within the scope of the service during routine antepartum and postpartum follow-ups, evaluate them via short screening scales, taking the high-risk groups into consideration and referring them for early diagnosis and treatment. Thank you.
Very nice presentation. I invite Dr. Nilma Deshpande ma'am to felicitate Dr. Sindhu Lakshmi.